Thank you, Dr. Sashi. My talk this afternoon is on preoperative evaluation of a LASIK patient. LASIK patient needs to be evaluated primarily to achieve the best visual results postoperatively. So first thing that you need to do is get a good history. You need to know about connective tissue disorders, diabetes, autoimmune diseases, history of ocular herpes, which is very important, old peripheral keratitis, medication the patient is using, an history of contact sports, which can be an issue in flap-based surgeries where the flap can be dislodged later on. Again, you can't emphasize more. One of the most important evaluations in LASIK is refraction. Your correction of the given patient depends upon your refraction values. So please do not trust any of the refraction values the patient could be carrying with him or her. This patient may be your patient for the last 15 years, could be followed by you. But when you plan any refractive treatment, re-refract as though it is a new patient, including duochrome, the works, the cross cylinders. Get the best refraction down. And you'll be surprised that the refraction would change by 0.5 to 0.75 or sometimes even more than what the patient has been wearing for years. Yes, I need not tell you about the most basic things. The patient should be ideally of 18 years and above, and you should have, if not 12 months, at least 18 months of stable refraction. If it is not stable, wait till it becomes stable. If you're doing anything for presbyopia, look at ocular dominance. The next one is keratometry. You need to do keratometry because you need to know what is a corneal curvature. Simply put, you can do it for several ways: automated, manual, IOL master, topography can give you the K. But most often, topography case or simulated case, so it's not wise to trust them. You should get a properly done K value. Once you have a K value that's over 48 or under 42, watch out. Over 48, you could be dealing with keratoconus. Under 42, you could have issues with the flap raising. So that is the next important step. Then comes pachymetry. You need to know the central corneal thickness accurately. Primarily because in every laser-based procedure, you are thinning out the cornea. You are also making the cornea biomechanically weaker by raising a flap. So you need to know the amount of thickness that you have and what would be the residual stromal thickness post-surgery. The most books or printed material will tell you that the residual stromal bed should be 250 microns. It is better to err in the side of positivity. I would still go with 300 microns. I would very rarely go less than 280. So that's being safe. And the amount of tissue removed per diopter of treatment would depend upon what machine that you're using and what is the software, and most importantly, what is the optical zone. As the optical zone increases, the amount of tissue that's ablated also goes up per diopter. So calculate that accurately. Pachymetry techniques can be ultrasound, which is the gold standard still. Non-contact would come from ASOCT. It could come from topographies, which are very accurate too. The limits here are difficult to ascertain, but rule of thumb, if you have a cornea that's less than 475 microns, preferably don't touch that cornea. Just because the cornea is very thick, you can't go gung-ho and just ablate 250 microns of the cornea just because the cornea has got 650 microns. Ideally, cut off somewhere about 150. Preferably don't go beyond 170 or 175 microns ablation, because once you go into more and more ablation, you would get a lot of unwanted higher order aberrations and poor quality of vision. Another rule of thumb is try not to ablate more than 25% of the total cornea. That meaning if you have a patient with 600 micron cornea, then you can ablate 150 microns. So that's another rule of thumb. You can mix and match these and decide about how to choose a patient. Slit lamp examination is extremely important to rule out meibomian gland disease, punctate keratitis. Dry eye is an important thing because most of your patients are contact lens wearers, have already got lid hygiene problems, have got borderline dry eye, which will probably worsen post-surgery, and the patient would be very, very unhappy. Look at any kind of a corneal membrane, anterior dystrophies, stromal dystrophies, check it out. Look for intraocular pressure, look for signs of iritis. Very important, don't miss out subtle lens opacities that can give you really poor quality of vision postoperatively. A posterior segment evaluation is mandatory, very detailed. Look for any kind of retinal weakness, look for holes, tears, treat them before you start doing anything on the cornea. Another important measurement is pupils. Often we miss out checking the pupils. You need to do a pupillometry. Most of your topographies today do an automatic pupillometry and tell you what is the pupil size in resting light conditions and in dark. You should remember that your ablation should be at least 0.5 millimeters more than the dark adapted pupil size. Then comes to topography. Probably one single most important test that you do for one single reason. You don't want to miss out early keratoconus or a posterior cone. That's the only reason you do topography for. Otherwise, if you're very sure that the patient has got no keratoconus and no forme frustae or no posterior cone, you don't need this at all. Absolutely nothing. You don't need it. You can go ahead with just refraction and the corneal thickness values. You need to understand and read topography in detail, which is a separate talk by itself, would take probably 30-40 minutes to cover. Just go through it very minimally. The topography flattens from center to periphery by about 2 to 4 diopters. Nasal is more flat than temporal. 41 to 47 is the average. Average is about 43.5. And usually the two eyes are mirror image of each other. And in case of any kind of astigmatism, it is usually more or less a symmetrical bow tie. An asymmetrical bow tie could be one red flag for early keratoconus. If you're using something like OpScan, you have one number up there which is the variability in the 3 millimeter zone of the flattest and the steepest of the posterior cornea. Anterior corneal keratoconus is easily picked up just by keratometry or by a normal topography. You need instruments that look at the posterior cornea. One of them is the OpScan. So if this number is more than 0.04, then you need to watch out. That means that the difference between the flattest and the steepest in the central 3 millimeter area of the posterior. The anterior is much easier to read. You can read the keratometric values, you know the steepness, you know the variability, you know the asymmetric bow tie is much easier to look at. One other point is more than 100 micron difference, but from center to periphery. This is normal, and so is this. In the 3 millimeter zone, if you have a difference of more than 2.5 diopters, then you probably are looking at an anterior cone. If you have this number of more than 0.4, then you're probably looking at a posterior cone. You really need to look at this, particularly this is what is the most important test. You don't want to touch a patient with keratoconus. You don't want to miss a patient with forme frustae keratoconus. You don't want to miss somebody with a posterior cone. The newer instruments, this is a full-blown keratoconus. You don't need, you look at the topography, there it is. You look at this asymmetric. You look at the posterior thinning. It's absolutely nothing to look at. But you should not miss out a subtle posterior cone. If you look at it here, it looks fine. The anterior looks fine. The keratometry looks fine, but the posterior is way off. And this is more than 100 there. So this patient has early posterior cone. If you don't look at the posterior curvature of the cornea, you can miss it and get into major issues postoperatively. The newer instruments such as the Sirius or the Pentacam go by certain nomograms that are available, and they would study and let you know whether it falls into the normal zone or outside the normal zone using the nomograms. Here you have one which tells you that the suspect keratoconus looking at the posterior cone. The eye trace is one more which can look at various parameters, but eye trace looks only at the anterior surface, not the posterior. Somebody spoke about the aura in the last speech in the last session. The aura is an instrument that will let you know the intraocular pressure by non-contact, but also looks at corneal hysteresis. Now, corneal hysteresis is one parameter that can be used to catch early keratoconus. So it's invaluable when you want to do refractive surgery to have access to an aura over and above having a machine that look at the anterior and the posterior cornea to be sure that you don't miss out any of the suspicious patients. So you have this nomogram which will tell you the chances of this person being normal is 0, being suspect is 2%, Being a mild cone is 24%, a moderate cone is 56% chance, and an advanced cone is 18%. So it gives you a kind of an evaluation based on the hysteresis and gives you based on a particular nomogram. So you have another patient here which has got a much higher incidence of chance of cone here. So one more armamentarium, one more instrument armamentarium to catch early cone. Don't miss out lens changes which could be responsible for the refractive error. Again, the eye trace is invaluable here. Here it tells me that the corneal aberrations are low, it's good, but internal aberrations are really bad. Either it is because of subtle lens opacities or really bad aberrations rising out of the lens. And that's the whole eye. So this person needs to be looked into very carefully with slit lamp to find out if this is any kind of an early lens change which could be responsible partly for the refractive error and which could probably change after you do the treatment. So please look at the lens very, very carefully. Look whether you can expose the globe adequately, that you don't have a really sunken eye, you don't have very short, small palpable fissures that could give rise to problems during your surgery. If a patient is a contact lens wearer, remove the lens at least a week or two before. Contraindications, there are some few endothelial dystrophies, one, retinal issues, autoimmune diseases, pregnancy, lactation. Severe dry eye which doesn't improve on treatment is probably a contraindication also. Thank you.